Next, Dr. Prithvi Chandrakanth will be talking on Phaco challenges before VIA surgery. Dr. Prithvi is a vitreoretinal surgeon and Phaco surgeon from Chandrakanth Nethralaya, Kozhikode. He is very well known for his innovations and innovative techniques.
Good afternoon, everybody. I'll be talking about Phaco challenges before vitreoretinal surgery. So, basic indications that we would want cataract surgeons to actually do cataract surgery is when there is media opacity. So it becomes very difficult for us to visualize the retina, and that is one of the most major reason for having the cataract removed. And whenever we feel that it's difficult for us to shave the base of the retinal, so that is when we want cataract again, because many a times what happens, the instrument goes to the other end and we touch the lens. So that we wouldn't want that when we are doing an extensive vitreous base shaving. So when anticipation of extensive vitreous base shaving is there, we always ask the patient to get a cataract removal done. And then if there is early cataract changes, and if we feel that it gets accelerated due to gas or silicone oil, and so that will actually cause more visual damage to the patient. So that is also one reason where we would ask ask them to get the cataract surgery done. So these are a few absolute indication where we require a cataract surgery to be done before. So what are the pre-operative planning and precautions that has to be taken? Case selections, that is one thing. Where do we do combined surgeries? So combined surgeries we can do when there is lens opacity which limits the fundus view. So and if the cases are such that it doesn't it take longer time, so we can do it. And combined surgery when dense VH prevents accurate retinal assessment, so that is when we can do both things. And early cataract expected to progress again, so that is where we can do such cases. And if there are short duration like epiretinal membrane or a macular hole case, which won't take much time and which requires very less amount of base shaving, so that is where we can do combined cases. What about stage surgeries? When corneal opacity or severe ocular surface disease are there, it is better to stage it. You do it, the cataract surgery initially, and then maybe 1 or 2 weeks later, when the cornea is more clearer, we can take him for retinal surgery. Any traumatic or unstable zonules are present, it is always better to stage the surgery, because if anything, nucleus drop can happen, or even intraocular lens cannot be placed. So in that scenario, we can actually wait for a week or two and then do the surgery along with the lens placement. So that is one thing. And any case which is one-eyed or a high-risk patient, it is always better to stage the surgeries. And always have a biometry ready for both the eyes when you take the patient for surgery. It is always better to do a biometry of both the eyes. And B-scan also is very required, because we need to know what the retinal status is before we take him for surgery. And it's always better to avoid multifocals in or any other premium IOLs when we have a patient who has a diabetic macular edema, or if we are expecting any tamponade like oil or gas. And medical optimization is very important. Maintaining tight diabetes and hypertension control. Coagulants should be adjusted properly, and eyelid diseases should be treated very well, because it's going to take a long time. Even if it's staged or combined, it is going to take both cataract and retina surgeries takes so much time. Better to treat them earlier. And ensure no active ocular inflammation, most common causes of macular edema also. So these are the few other medical optimization that we have to take care of. And another thing which I forgot to tell over here was biometry. Always consider what is inside. Like if it's vitreous, if there is no oil or any tamponade, you have particular options in your biometry which you can select before doing the surgery. And cases of in macular hole surgeries also, you might have a little bit of refractive error, because of the retinal thickness is lost over there. So that also has to be explained to the patient very well in advance. So that is about biometry. And patient counseling, like I was saying, patient potential need for gas and oil and posturing has to be explained very well. And there will be a slow visual recovery in complex cases, especially diabetes. And risk of macular edema and inflammation can occur. And possibility of secondary procedures should be explained well in advance to the patient so that they understand what they're getting into. What do we expect during a capsular excess? Uh, it is always better to create a 5 to 5.5 capsular excess. That is ideal, because we need, if it becomes small, then you get these kind of phimosis, and you can see how opaque these capsules are. It becomes very difficult for us to actually visualize the retina during retinal surgeries. And large CCC leads to IOL instability. What happens is the haptic or the optic edge comes in between the pupil, and it becomes very difficult for us to actually toggle between the retinal surgery. It comes in right in between the refraction, both sides becomes very difficult. So it was always better to have good rexes. And over here you can see how this cortical material has come right in front, in between the IOL and the posterior capsule, and this becomes very difficult for us to do the surgery. But we can actually do we cut the PC from behind, and it becomes very clear for us. So this is another thing which I was saying. If IOL instability is there, it comes right in between our surgical view, and it becomes very difficult for us to do the surgery. The next one is chamber stability. So using good dispersive OVD to protect the endothelium and minimize phaco energy and time for corneal clarity, because this will affect our surgery if you're doing it on the same day. So combined surgery, always better to use less phaco energy and good OVD to protect the endothelium. If the view is very hazy, it's always better to stage the surgery, and this has to be told to the patient that always when you're combining any surgery, it is always better to tell them 90% we are going to do the same day, but there could be some complications. So 10% maybe you'll have to stage the surgery so that they understand what the risks are also. And then post-capsular rent, if PCR occurs, you stop the phaco immediately, perform controlled anterior vitrectomy, and always see if there are good capsular support. And it is always advisable that you place a 3-piece IOL, because even if it falls down, we can actually use the same IOL and fix it to the sclera. So it is always advisable to place, if the PCR occurs and there are little good support over there, it's always better to keep a 3-piece IOL. And also the PCR, if it's too big, if you put oil also, it might also come to the antechamber. So this has to be explained to the patient also when we are staging the surgery. And we have to do a good anterior vitrectomy so that it reduces vitreous traction, minimizes the retinal complications, and always avoid fishing of fragments from the posterior segment. Another thing is IOL selection. Like I told you, if it's in the back, it is the best place. If not, if there are zonular compromises, and if you cannot place a 3-piece IOL, always better to leave it aphakic, because we'll take care during the second surgery. Yes, and then suture sites, always most of our cases we would ask them to actually suture the incision site, because during during indentation, scleral indentation, it could open up and the AC would go shallow, and also a lot of hyphema and other things could happen. So always suture the incision site in all VR cases. That is very important. Retina specific, again, in PDR TRD cases, you can do anti-VEGF on the day of the cataract surgery, and cases like diabetic cases will always have a very bad leathery cataract, so it is very difficult to actually chop and crack these cataract cases. So always it's better to stage the surgeries and not do in the same day. And if it's a very short duration surgery, you can always go with combined. If not, it's better to stage it. Other things over here, if you have a VH case, and always you can see over here the anterior vitreous face is so sticky because it's filled with the vitreous hemorrhage. it's very difficult to actually get the view. So you need to remove this sticky when it is stuck to the lens. Better to do a cataract surgery and then go ahead with such cases. So this can be identified right in the slit lamp itself. Otherwise, we will be struggling to remove the sticky anterior vitreous face. And then in RRD, like I told you, combined if it is minimal peripheral work. If not, if you require a very good base dissection, always go for a stage 1. Macular hole and ERM can be done combined, if not for, thank you.
Thank you, Prithvi. Covered almost all the aspects that were